There we are. It looks like everything is working the way it's supposed to be. And good afternoon or good evening, as the case may be, to the CNY Nation. Live coast to coast, I'm Dr. Randy Fink, and welcome to Fertility and Friends from CNY Fertility here in Colorado Springs. I am so happy to have you all with me today, and a very wonderful Happy New Year to everybody. Everybody's logging on there. It looks like most people are on the Instagram side, so thanks for that. We'll see some people on the Facebook side here very shortly. But it's another beautiful day in Colorado. Thank heavens I didn't have to travel today because I came in actually last night from a little vacation last week and through the Denver airport. And oh my heavens, it was a disaster. But fortunately, I made it. No missed flights. I don't have to fly Southwest Airlines to get to my job here at CNY. But we're here at CNY Fertility Colorado. I am also the medical director at the Miami Center of Excellence for Obstetrics and Gynecology in Miami, Florida, which is a CNY monitoring center. So for those of my friends in South Florida, hi to you as well. I hope that this year is going to bring to all of us everything that we want and hope for, especially in terms of fertility, because gosh, it's quite a journey, and we all know what it takes out of us. And I'm just glad to be a part of your lives. And we at CNY here are really happy to be able to participate in making your dreams come true. Well, we will have a special guest here a little bit later on in the broadcast, but it's about 3 minutes after the hour, live from Colorado Springs. And what I thought we might talk about today are some of the most common questions that I hear asking about IVF and fertility, and some of the myths that we hear about IVF and fertility. And I'm going to hold off on some of those myths until my special guest joins me a little bit later on, because she knows all about those things. So let's ask some of those common questions. And if you have questions about your IVF journey or about your fertility, please go ahead and submit them to us. We'll do our best to try to answer them here for you. Let's see. I did get something here from Ariel. Hello. I start my trigger shots tonight. Oh, good. Thursday is the retrieval, and you're going to do a fresh transfer. It said spouse has ejaculated 2 days ago. Does he need to tonight if we'll be mixing sperm and egg? You know, that's a very good question about the frequency of ejaculation and how that affects sperm. So the common wisdom was all that what used to be that we would tell you, we want you to save it up. Because as you might imagine, if you ejaculate multiple times, or if the male obviously ejaculates multiple times during the day for a collection late in the day, then the concern might be that the sperm count is going to progressively go down each time with each ejaculation. But there is something that's called DNA fragmentation. DNA fragmentation is what is a sperm anyway? Well, all right, we've seen the little spermies, we know what they look like, but what are they actually doing? Well, it's a little genetic pod, if you will. It's a little piece of genetic material with a motor attached to it, right? And that's that little tail that takes it along and gets it where it has to go. So that's what a sperm is. DNA fragmentation, which is one cause of infertility, which is commonly when the sperm just doesn't easily fertilize the egg, happens because of the DNA, the genetic material, as it sounds like, it becomes fragmented. Instead of being in a nice even piece, it starts to break apart. Well, one cure for DNA fragmentation is the frequency of ejaculation. So if we know that the male partner has an issue with DNA fragmentation, we will advise that he ejaculates multiple times. So the question we had here is that he ejaculated 2 days ago. If Thursday, which is 2 days from now, should he continue to ejaculate more? The truth is, I don't think it really matters because, again, when it comes time to do IVF, the sperm count is not going to be critical for us. So the average ejaculate might have, let's say, 35 to 50 million sperm. Well, if there's a problem where the sperm count goes down to, say 10 million, well, 10 million sperm is a lot less than 50 million, right? But how many sperm does it take to fertilize an egg? One. So as long as they can find one sperm for one egg, we'll do okay. In general, we tell people 48 to 72 hours without ejaculating prior to collection for IVF, but there are situations where that changes. So Errol, thanks so much for that question. Again, if you're just joining us, so glad to have you. Gosh, we're getting all kinds of questions here on the Instagram side. Let me see if I can get back and find the one I just saw. Hi, Kathy. Can't wait to come next month, and we can't wait to see you. Let's see here. Growing your family. Well, gosh. Okay, here's one from Lady Olivia. 2 failed frozen embryo transfers, which is a very frustrating situation, as we know. And I don't like to call them failed transfers. They were unsuccessful transfers, which doesn't mean that they won't be successful again in the future. And I think putting that positive foot forward really does make a difference. So Lady Olivia's question is, should I suppress with Orilissa prior to doing another FET? So Orilissa is a medication that we use to treat endometriosis. Endometriosis, I'm going to make an assumption that everybody knows what endometriosis is, but if not, endometriosis is where the lining of the uterus that normally sloughs off when we have a period, instead of coming out, works its way up to the inside and implants within the pelvis. Now, in many people, endometriosis is a clinical syndrome. It's the most common cause of severe painful menses, which is what we call dysmenorrhea, and is classically diagnosed with a laparoscopy. So in the olden days, we would tell everyone, you need a laparoscopy. In fact, in my days of training, people would have a laparoscopy before they even, they'd be scheduled for that laparoscopy before they ever even met with the doctor. We can now diagnose endometriosis through non-invasive means, and that's through a test that's called Receptiva. Receptiva is an endometrial biopsy that's done at a special time during the cycle, where a small straw is placed inside the uterine cavity and a little tissue is removed. That's looking for a particular protein that's called BCL6. And that protein is expressed in women who have endometriosis. If we find that you have endometriosis, well, imagine it's basically uterine lining that's in the wrong place. And so it interferes with what the brain is saying to the uterus as it pertains to your ability to implant a pregnancy. And that's the reason that certainly at least moderate and severe endometriosis can contribute to fertility problems. And so usually if we find a positive test for endometriosis, we recommend that we suppress that endometriosis before treating it. And that's what Olivia is asking about. Should I use Orilissa prior to that next transfer? Well, certainly I think it's worth evaluating for the presence of endometriosis. The medications that we use, Orilissa and Lupron, they can be expensive if insurance doesn't cover them. I think it's certainly reasonable to know what we're treating there rather than to treat that empirically. So that's my answer there. Hi to Joy. Joy says, I found out I had fibroids at 42 and had surgery to remove them. So that's called a myomectomy. A fibroid is a leiomyoma. And removing a fibroid is a myomectomy. Joy got pregnant naturally 2 months after surgery. That's great. Oh, but lost it due to miscarriage. Oh boy, that's frustrating. Joy's now 43 and still trying naturally. Is IVF still an option? So there's two questions there. There's two things I'd like to address. One is, what the heck are fibroids? And why do so many people have them? Well, in fact, 70% of women have some evidence of fibroids in the uterus. Fibroids are balls of muscle. So the uterus is a little organ that's made up of muscle. And the job of that muscle is, of course, to squeeze the baby out when that time comes. As these cells come together and form a little sheet that makes a nice hollow organ, that's what a normal uterine muscle is like. But sometimes as these cells come together, one of those little cells can get knocked off, and instead of forming a sheet, it forms a ball. Those balls of muscle are uterine fibroids. Up to 70% of women have uterine fibroids, and in most people, they make no difference at all. In some people, they can create problems with bleeding and pain. They can create problems with bulk because as they get larger, they can sit on top of the bladder and cause pain, cause bladder symptoms like having to go to the bathroom constantly, or an increase in abdominal girth, kind of hard to get your pants buttoned because you feel your belly is just getting bigger. Those are called bulk symptoms from fibroids. Usually, when fibroids do not involve the uterine cavity, they are not specifically a problem as it pertains to fertility. However, in this case, fibroids were removed. That's a good thing. Do you think that the fibroids and the surgery had anything to do with the miscarriage? My guess is no, because at 42, the problem that we have even in nature is that the DNA, the genetic material that's in the eggs, becomes less stable. And as that happens, there's just a greater probability of either an egg not being able to be fertilized by a sperm or fertilization taking place that results in an embryo that does not have normal chromosomes. And that's the most common reason that someone has a miscarriage. And that's why it's harder to get pregnant in our 40s naturally. And of course, in the IVF process, it gets progressively more difficult as well. Is 43 too old? And that sounds like it's question number 2. Is there an age limit to IVF? The answer is yes and no. At CNY, we like to be able to offer everyone the chance to be able to get pregnant if they can. As we approach our mid 40s, it becomes progressively less likely that we'll be able to achieve a pregnancy using our own eggs. And so this is when we start to have conversations about using a donor egg. And we'll talk a little bit more about donor egg, I think, a little further in the broadcast, because there's a couple of important things I want to be able to say about that. So in the CNY system, people at 43 get pregnant every single day. In an average IVF clinic that does about 150 cycles per year, and that's the typical number kind of for an average IVF clinic, you may not see a 43-year-old getting pregnant that frequently. But in our 15 to 20,000 cycles a year, it definitely happens. There are a lot of variables there. It depends on your own ovarian reserve, but certainly is worth a conversation. Joy, thanks so much for your question. Melissa, congratulations. Your transfer worked. You got a very wonderful little Christmas present there. So let's just say congratulations to you. I'm going to switch over here to the Instagram side. I'm wondering, this comes from Jeannie, if for women in their late 40s with regular cycles and good egg reserve to go straight to donor eggs due to age, or to use your own eggs? A great question. And that really goes back to what we were just talking about here. Again, at CNY, we like to be able to offer you the opportunity to use your own eggs as long as we are realistic about the possibilities. And that is beyond 45, it becomes very difficult to be able to achieve a normal pregnancy with your own eggs. Not that it's not worth a try, but some people will opt to do things like a donor egg backup. A donor egg backup is where we will stimulate your ovaries, retrieve your eggs, but at the same time, we have a group of donor eggs that you've purchased that can be fertilized as well. So whether we have embryos that come from your eggs or embryos that come from the donor, one way or the other, we are going to have an embryo with a high probability of being able to get you pregnant. So options there for everybody. This is probably a good time to just talk about donor eggs since Jeannie was kind enough to bring it up there on the Instagram side. I used to tell people that a donor egg, it's a hard choice to make because we all have in our hearts that we want to have our own children using our own genetic material. And yes, it's certainly true that using someone else's genetic material in the egg will predict what color the eyes and the hair are going to be. No question about that. That genetics comes from someone else. However, there's something that has come to light in the last few years that's called epigenomics. Epigenomics. And if you're not familiar with it, I think it's worth looking up because it's really a very interesting topic. Epigenomics tells us that while it's true, I could have told you beforehand, that if you're carrying a baby that came from donor eggs, every drop of blood in that baby is yours. There's no question that that baby is yours. Every drop of blood comes from mom who's carrying that baby. But epigenomics tells us that there are maybe 1 million different switches that can all be turned on or off in any different combination. So think about the number of possibilities of the way those switches can be on or off 1 million different times. The number is staggering. Epigenomics tells us that the way those switches are on or off is dependent upon the environment in which that embryo grows, which means your uterus. So the epigenomics is what's going to tell us, is that child going to be artistic or mechanical? Is that child going to have a beautiful singing voice or be a great author? Will your child play violin or the French horn? Whichever the choices are based on the way those switches are turned on or off. Will this child be shy or gregarious? Will this child like to have his or her hair fluffy or like to have it flat? Those things are going to be based upon the switches that are turned on or off based upon your uterus. That's epigenomics. So in addition to every drop of blood being yours, all those decisions about what happens with that embryo and how that child is going to grow are really dependent upon your own uterus. So if there was ever any doubt that that's 100% your child, that really proves it for us. Epigenomics is what that's called. And that's one reason not to fear donor egg. So let's see what else we have here. Here's one from Thomas. Can meds for gout affect sperm count? So typically allopurinol is used for gout, and I'm not aware that it causes any issues with sperm. But again, remember, when there is a lower sperm count, as far as IVF goes, we really only need one sperm to make that process work with one egg. And even with an IUI or an intrauterine insemination, we can still try to select out the best and the strongest sperm, and of course the ones with the best senses of humor, the best dressed, and that sort of thing, in order to maximize the potential of being able to fertilize the egg. Oh, let's see here. What else we got going on here? What is, here's a good one. What's the lowest AMH that's acceptable for IVF? The AMH, the anti-Mullerian hormone. That's the blood test that we do that tests for what we call your ovarian reserve. So very commonly, if you talk to a reproductive endocrinologist, the question will be, what's your AMH? Do you know what your AMH is? The AMH is a simple blood test to do. And it tells us, roughly speaking, how many eggs you might have left. Now, it doesn't quantify things. We're born within the ovaries with all the eggs you'll ever have. And over time, we start to lose those eggs. The AMH is a general reflection on how many eggs there are left. So when we have an AMH that's less than 1, we consider that number to be consistent with what we call diminished ovarian reserve, or sometimes just advanced reproductive age, because as we age, the number starts to go down. And when we're dealing with an AMH that's less than 1, we have typical protocols that we use for women who have a diminished ovarian reserve. And that's kind of the way that works. Hey, again, thanks so much for being here. About 22 minutes after the hour, getting all kinds of great questions here. Jenica says, I'm from Florida. Well, you know what? I used to be, but now I live in Colorado, and it's not such a bad place. I didn't have to look at the hurricanes. I didn't have to look at the tropics at all this year. I only had to deal with snowstorms and a mama and a baby bear coming into my garage to eat from my trash can. So, boy, how times change, don't they? Hey, at this point, I would like to ask my very special guest to join me here. If you don't mind, stepping in with me here right now is Brandis Montez. Brandis is the nurse practitioner here at CNY Fertility in Colorado. And Brandis, I'm very happy to have you here today.
Hi, guys.
There she is. Okay, let's see if we can get the Instagram side to be able to see you a little bit without that microphone being in the way. I'm going to try to move this over here a little bit. There she is. All right. I wanted to talk a little bit about some of those myths that people talk about as it pertains to IVF. And so the one that we hear all the time is after a transfer, people say, what?
They're going to go get French fries.
The French fries. You've got to have French fries. Now, I've heard different things. It's McDonald's French fries. I happen to think Five Guys fries are pretty good myself. I heard somebody say, no, it has to be Wendy's. I'm not sure there's any science to back that up, is there?
No. So usually it's McDonald's, I think. But it doesn't matter what kind of fries. People always just go get fries after. That originally actually came from egg retrievals. So sometimes if you get ovarian hyperstimulation syndrome or OHSS, meaning you just responded really well to those medications that we gave you, you can often build up a lot of extra fluid from that estrogen. And so originally, the fries or the extra salt was thought to help kind of absorb that fluid. And then people took it and ran with it. And now people get fries after embryo transfers. So even though it doesn't really have any science to back it up, fries are good. And it's kind of a fun tradition.
I don't mind French fries. I'm just stating for the record there. Hey, here's a good question. Do women with PCOS need to do IVF or IUI, and which is best? And my answer would be it kind of depends on your situation. What is the difference between IUI and IVF?
So IUI, we give you medications to help you get a follicle. or an egg to grow on its own. We monitor you. Typically, when you have a mature egg, we trigger you to ovulate, and then we do the insemination in clinic. With IVF, we take the eggs out, we fertilize them with sperm, and we put an embryo back in.
So women with PCOS, typically, PCOS is polycystic ovarian syndrome, and typically women with PCOS don't ovulate or release their egg in a normal and predictable fashion. Now, PCOS can be a broad spectrum. And there's a lot of different things that can fall into that definition of PCOS. One of the ways that we predict that your ovaries will respond like PCOS, like a PCOS patient, is through that AMH level. And typically we think of if that number is above a 5, we expect that your ovaries will respond like PCOS. So for someone who doesn't ovulate, there are medications that we can give you orally to get your ovary to release an egg, in which case an IUI might be a good answer. IVF gives us a higher pregnancy rate. What do you quote for IUI success rate?
About 5 to 7%. Typically per cycle, which is pretty low compared to, if you have an untested embryo, 30% or 60 to 70% with a tested embryo. And the other thing, I always tell patients to think about is if you're, 35 and starting this process and you want more than one kid, maybe it's time to think about IVF for the reason of you can freeze embryos and you don't need to worry about, you have a baby. I want to breastfeed for a while. Should I stop breastfeeding so that way I can have another baby? If you have embryos frozen, you don't have to rush the process to have another kid. So that's something else to think about.
Let's see. There was a question I wanted to ask here, but then this just caught my eye. We're thinking of the donor egg root with an AMH of 0.68. I always see 2 numbers, not 3. I guess I'm not sure what you mean by that, but if you're talking about the 0.688 versus a 0.68, I think that's just the way the lab reports it and how the number is rounded. That third digit probably doesn't have a lot to do with fertility-related outcomes. Now, the other question I want to ask here, or answer here, is about the thyroid, which is another thing that we see pretty commonly in our patient population, that the thyroid, it may be that you've gone to your primary and have been told that your thyroid is completely normal. And then you come to us and we say, oh, actually, we want to treat your thyroid. Is that because something is wrong with their thyroid?
No. So we like thyroid. Some normal ranges, can go up to 4. Typically in fertility, we like it to be 2.5 or below. And that is because in the first trimester, baby relies on mom for that thyroid hormone before they develop their own. And so that's kind of why we like those thyroid levels to be 2.5 or below when you start treatment.
And so the way that works is that the higher the number of the TSH, the thyroid stimulating hormone, which is the blood test, the higher that number, the lower the function of the thyroid. The lower that number, the higher the function of the thyroid. So when we say we want a 2.5 or lower, we're talking about just turning up the volume knob of the thyroid gland a little bit in order to try to improve the fertility. Thanks, Pam, for that question. Hey, here's one. And if you come here, you'll see it. In fact, look right behind me here. One of our beautiful patients made this. It's a lovely knitted pineapple. What is the deal with the pineapples?
Yeah, so the pineapple, is actually a thing for transfers as well. The core of the pineapple has bromelain in it, which is thought to be an anti-inflammatory. And we know that inflammation can prevent implantation. So some people think that it, can help with inflammation and kind of decrease or increase blood flow to the uterus. Kind of the same thing with the Brazil nuts and the socks. So some people think, warm feet equals warm uterus equals implantation. So the socks are from, and Brazil nuts, that's another thing for transfer. So they have selenium in them, so people think that it can increase blood flow to the uterus. So all these different things typically are thought to either, thicken lining or help with that embryo implantation, but it can't hurt. So.
And pineapples aren't a bad thing, right? So French fries and pineapples, that seems to be the lesson of the day here. Here's a question. If we have 2 unsuccessful transfers with day 3 embryos, would it make sense to try to push our next one to day 5 before transferring? Well, we've talked about this kind of thing before, and that is what's the difference between a day 3 and a day 5 embryo? Because that's really what this comes down to, Brandis.
So a day 3, obviously is done on day 3, and day 5 is day 5. So we typically have something called CNY protocol. So if you have 5 or more embryos, we would recommend trying to grow those to the blast stage, which is that day 5 that you're talking about. Or if you have 4 or less, at day 3. And the reasoning for that is because you can lose some embryos as you try and grow them out to a blast in the lab. And we would rather see you get to a transfer just because, no matter how good the lab is, it will never be exactly your uterus. So that's typically the reasoning. I would tell you, though I don't know the name of who asked this, but I would tell you, you could try and grow to day 5. The other thing I would have you think about is, have you looked at other things? So not always is it always the embryo. Have you had a uterine cavity evaluation? Have we, done labs in a while? Has everything else kind of been looked at? So not just embryo, but look at uterus as well.
Hopefully that answers your question there. Yep, I agree. Here's a question. What is an AFC? The AFC is the antral follicle count. And what that is where we can do an ultrasound at the beginning of the menstrual cycle and see how many undeveloped follicles there are. And a follicle is a little space with an egg inside. Now, there's actually millions of eggs inside the ovary, so we don't count millions of them, but there's a group that develops each cycle. And one of those eggs emerges as what we call the dominant follicle, and that's in a natural kind of menstrual cycle. If we can see all the eggs that are gathered together at the beginning of that cycle and count them, that's said to have some predictive effect, factor on how people will do with stimulating the ovaries. In fact, though, the count of those can be very subjective. It's sometimes hard to count them all. It's sometimes hard to even see them all. So at CNY, we don't typically use an antral follicle count as any real predictor. We're kind of more interested in the AMH, the anti-mullerian hormone, which comes from the blood. Hey, Heather has a good question here. Is IUI more successful if someone is young and healthy and has no fertility problems? Well, if you had no fertility problems, I would ask, why are you doing an IUI? IUI is very common in our same-sex couples. So many same-sex couples, female couples will purchase donor sperm or have a known donor and do an artificial insemination, or as we call it, an IUI. And their success rate is typically a little bit higher than someone who is doing an IUI for other types of fertility problems. But again, so many different types of fertility issues. And hopefully that answers your question there. Hey, there's one more thing I wanted to ask. I don't know if you guys all last week, Brandis did a wonderful live here where she talked about the menstrual cycle and egg freezing. And there was one thing that you said, Brandis, that really struck me. And I've heard it from patients before. First of all, so that everyone understands, the process of egg freezing is a fertility preservation procedure where we can stimulate your ovaries, retrieve the eggs, and then store them for you for future use in case you need them. Doesn't mean you ever actually have to use them, but it gives you the opportunity to use them should you need to. So it's like purchasing an insurance policy in many ways. And I've heard from patients before that their doctors told them, no, you're too young to have to worry about that. Forget about that. And your answer was, if your doctor tells you that you're too young to worry about that, what should you say to them?
I would go see someone else.
Find another doctor. I agree with that. And explain to us why that is. That really struck me.
Yeah, so if you're, the older you are, like I said, two things happen. So you lose, we lose eggs. And then the other thing is that those chromosomes become more unstable. So it's going to be harder to get, not only eggs, but to get eggs that are chromosomally normal. And so the younger you are, the less cycles you're going to have to do and the less eggs you're going to need per live birth. So really, if you're 25 and think, you know what, I don't want to have to worry about this. Should I freeze eggs? I won't have to worry about this until I'm 35. My advice to you would be do it now, do it while you're young. You could get a ton of eggs. More than likely, most of them are going to be chromosomally normal. It's going to be easier for you to respond to those medications. And it's just, the younger you are, the better.
My friend Amber in Kentucky, hi Amber. Amber says she agrees. She's 32 and she has a diminished ovarian reserve and what we'll call a low egg quality. And she so wishes that she had. And I will tell you that the process of egg freezing has become so much easier. It used to be something that was really a far-fetched notion that was hard to execute. And in many places still, it can cost $20,000 for a single cycle. At CNY, I should have looked on the website to see what that price. It's less than the cost of the IVF, and we're already the lowest cost IVF in the country. I believe it's $2,900, I think, to do a cycle of egg freezing. It's on the website. Honestly, it's probably one of the better investments I think anyone can make. Potentially in being able to have a family, because the earlier we have those eggs, the better off we are. And again, no reason you have to use them, right?
Yeah, no. So you may, get pregnant on your own just fine. I know somebody that, did freeze eggs and did get pregnant on her own just fine. And then for her second child, she was a little bit older. And so she ended up using some of the eggs she had frozen. So good, nice to have.
Thanks for the info, Amber. Our internet sleuth, $29.95 for a cycle of egg freezing. And gosh, it's something that we just love to do. We'd love to talk to you more about all of this, not just egg freezing, but about your fertility journey. Anything we can do for you, we're always here. Brandis and I are available over the telephone for consults. We'd love to see you here in Colorado. It's a beautiful place. To be honest with you, the whole CNY system is really made up of very good people with one super important goal in mind, and that is to get you the family you want and deserve. So God bless you all. We certainly hope we'll be able to help you on this journey. It's about 40 minutes into the presentation here, so we're going to wrap it up for tonight and say thanks so much for joining me here. And Brandis, thanks for being here. This is Fertility with Fink and Friends, live from Colorado Springs and CNY. I'm Dr. Randy Fink, and we'll see you next Tuesday. Please tell all your friends. We're on Instagram now as well. The first few were just on the Facebook and the YouTube side. But we're here and looking forward to talk to you. Happy New Year, everybody. Thanks for being here.